If you are on Medicare right now, I want you to think about the last time someone sat down and explained to you in plain language exactly what your plan actually covers, what it doesn't, and what changed this year that directly affects how much you pay. For most people, the answer is never. You got your Medicare card, you got a thick packet of paperwork, and you've been figuring it out on your own ever since. And here's the problem with that. Medicare changes every single year. Premiums change, drug cost rules change, what counts toward your deductible changes. New benefits get added, old rules get updated, and the people who know about those changes pay less. The people who don't know about them keep paying the old amount, sometimes hundreds, sometimes thousands of dollars more than they have to. In 2026, 5 specific Medicare rule changes are putting real money back in the pockets of seniors who know about them, and costing real money to the ones who don't. One of those changes is the most significant Medicare drug cost reform in the program's history. Another one is a benefit that most Medicare members have had all along, but have never been told about. A third one affects your premiums directly, based on income you earned 2 years ago, and there's a way to fix it that most people never use. I'm Marcus Gave. Today's video is specifically about Medicare, what changed, what it means for your out-of-pocket costs, and what you can do right now to make sure you're getting every benefit you're entitled to under your current plan. This is going to be a thorough video because Medicare deserves a thorough explanation. Get comfortable, get a notepad, and let's go through this together. Subscribe before we start. This channel is where Medicare and Social Security updates get explained the way they should be, in plain language, before the open enrollment window closes and before the rule changes cost you money you didn't have to spend. Let me start with the change that is, without exaggeration, the most significant improvement to Medicare drug coverage since the program was created. Starting January 1st, 2026, there is a hard cap on how much you can spend out of pocket on prescription drugs through Medicare Part D. That cap is $2,000 per year. I want to make sure you fully understand what that means, because this is genuinely new territory for Medicare. Before this rule, there was no ceiling on what you could spend on prescription drugs in a calendar year. If you had cancer, if you had a rare disease, if you were on multiple brand name medications for chronic conditions, you could spend $10,000 or $15,000 or more in a single year on drugs alone. That was the reality for millions of Medicare beneficiaries, and for many of them, it meant choosing between medications and food, medications and rent, or simply not filling prescriptions that their doctors said they needed. That is over. As of 2026, once your total out-of-pocket drug spending reaches $2,000 in a calendar year, you pay nothing more for the rest of the year. Zero. Your Part D plan covers 100% of additional drug costs from that point forward. Now let me break down exactly how this works in practice, because the mechanics matter, and there's a part of this that most people are confused about. The $2,000 cap counts what Medicare calls true out-of-pocket costs, the amounts you actually pay at the pharmacy. This includes your deductible, your copays, and your coinsurance. It does not include your monthly premium. Premiums are separate and do not count toward the $2,000. For most people on standard Part D plans in 2026, the structure looks like this. You pay a deductible. Up to $590 is the maximum allowed deductible for 2026 standard plans. After the deductible, you pay your plan's cost sharing, typically 25% of drug costs, until your out-of-pocket spending hits $2,000. At that point, you enter what Medicare calls the catastrophic coverage phase, and you pay nothing for the rest of the year. Here's where this becomes specifically meaningful for the people watching this video. If you are on high-cost specialty medications, drugs for cancer, rheumatoid arthritis, multiple sclerosis, diabetes, and many other conditions, you have likely been spending well above $2,000 per year on drugs alone. In 2026, your annual drug spending is capped. Whatever you were spending above $2,000 in prior years is now protected. If you are on lower cost generic medications and your total annual drug spending is under $2,000, this change may not directly affect your out-of-pocket costs, though it does provide protection against the unexpected. A sudden diagnosis, a new prescription, an emergency, your exposure is now capped at $2,000 regardless of what happens. And here's a new option that makes the $2,000 cap even more accessible for people on fixed incomes. Medicare is now offering what they call the Medicare Prescription Payment Plan, also referred to as the M3P. This allows you to spread your out-of-pocket drug costs across the calendar year in monthly installments, rather than paying large amounts at the pharmacy all at once. Instead of facing a $400 payment at the pharmacy in January when you're filling expensive medications after your deductible resets, you can cap your monthly payment and spread the cost out smoothly. This does not change the total amount you owe, it only changes when you pay it. But for people managing a fixed monthly budget, that smoothing can be genuinely significant. To enroll in the Medicare prescription payment plan, contact your Part D plan directly. You can find your plan's contact information on your Medicare card or at medicare.gov. One important thing I want to flag about the $2,000 cap. It resets every January 1st. So if you're approaching your $2,000 limit late in the year, say in November or December, consider whether any prescriptions that could be filled in December should instead be filled in January when the counter resets. That's a small but practical planning point that can save money for people on high-cost medications. Okay, let's talk about something that lands in a lot of people's mailboxes and causes immediate frustration, and where most people have no idea they can push back. Medicare Part B and Part D premiums are not the same for everyone. The standard Part B premium in 2026 is $202.90 per month. But if your income exceeds certain thresholds, you pay more, sometimes significantly more, on top of that standard premium. This additional charge is called IRMAA, the Income-Related Monthly Adjustment Amount. Here's how it works. Medicare calculates your 2026 premium surcharge based on your income from 2024, 2 years ago. They get that information directly from your tax return through the IRS. If your 2024 income exceeded certain thresholds, $106,000 for a single filer or $212,000 for a married couple in that tax year, you're paying more than the standard Medicare premium right now in 2026 because of what you earned 2 years ago. The surcharges are structured in 5 tiers. Each tier represents a higher income range and a higher monthly premium. At the highest tier, individual income above $500,000 or joint income above $750,000, the Part B premium can exceed $600 per month. But even the lowest IRMAA tier adds roughly $73 per month to your premium, which is nearly $900 per year in additional costs. Now here's the part that most people don't know. You can appeal IRMAA if your income has dropped significantly since the year Medicare is looking at. This appeal process is called a life-changing event appeal, and it allows you to ask Medicare to use more recent income, rather than the 2-year-old tax year, to calculate your premium. The qualifying life-changing events that can trigger a successful appeal include retirement or reduction in work hours, the death of a spouse, divorce or annulment, loss of income-producing property, loss of pension income, and an employer settlement payment. Retirement specifically is one of the most common qualifying events, and it makes sense, because if you were working in 2024 and retired in 2025, your current income is likely dramatically lower than the income Medicare is using to calculate your 2026 premium. The appeal form is called SSA 44. That's the Medicare Income-Related Monthly Adjustment Amount, life-changing event form. You file it with the Social Security Administration, not with Medicare directly. You can download Form SSA 44 from ssa.gov, complete it, and submit it along with documentation of the qualifying event and your more recent income information. Processing typically takes several weeks. If approved, your premium is adjusted going forward, but the adjustment is not retroactive to the months you already overpaid before filing. That last point is important. The sooner you file the appeal, the sooner the reduction takes effect. If you retired last year and you're currently paying an elevated Medicare premium because Medicare is still looking at your working income from 2024, filing the SSA 44 appeal now saves you money for the rest of 2026 and positions you for a lower baseline calculation going into 2027. For anyone who is not currently subject to IRMAA but is planning major income events in the near future, a large Roth conversion, a home sale, a large IRA distribution, remember that the income you recognize this year in 2026 will affect your Medicare premiums in 2028. That 2-year look-back works in both directions. Planning large income events with that timeline in mind can prevent an IRMAA surcharge 2 years down the road. This is the section where I want to talk about free benefits that are already part of your Medicare coverage. Benefits you've been paying for through your premiums that most people never use because nobody told them clearly what they were. Medicare covers a significant number of preventive services at zero cost to you. No deductible, no copay, no coinsurance. These services are free when provided by a Medicare participating provider, and they include things that can genuinely catch serious health problems before they become life-threatening and expensive. Let me walk through the ones that are most commonly overlooked. The annual wellness visit. This is not the same as a regular doctor's visit or a physical. The Medicare annual wellness visit is specifically designed to create a personalized prevention plan, review your current health status, check your cognitive function, review your medications, and identify risk factors. It is free under Medicare Part B once every 12 months. Most Medicare beneficiaries don't know it exists as a separate benefit, and many who do know it exists don't schedule it because they assume it's covered the same way as a regular office visit. It's not. It's specifically free with no cost sharing when billed correctly. Here's a practical tip on this one. When you call to schedule your annual wellness visit, use those exact words, annual wellness visit, so the office bills it correctly under the Medicare Preventive Care Code rather than as a regular office visit. The difference in billing codes determines whether you pay a copay or pay nothing. Cancer screenings. Medicare covers annual mammograms for women 40 and older at no cost. Colorectal cancer screenings, including colonoscopies, are covered, with the frequency depending on your personal risk. Lung cancer screenings with low-dose CT scans are covered for current or former heavy smokers between 50 and 77. Cervical cancer screenings are covered. Prostate cancer screenings, the PSA test, are covered annually for men 50 and older. None of these require cost sharing when provided by a participating provider. Cardiovascular screenings. Medicare covers cholesterol, lipid, and triglyceride tests once every 5 years at no cost. Cardiovascular behavioral therapy is also covered to help reduce cardiovascular disease risk. Diabetes screenings and services. If you have risk factors for diabetes, Medicare covers up to 2 fasting glucose tests per year at no cost. Diabetes self-management training is covered, up to 10 hours of initial training and 2 hours of follow-up training per year. Diabetes prevention programs are covered for people at risk, and medical nutrition therapy is covered for people with diabetes or kidney disease. Depression screenings. 1 screening per year for depression is covered at no cost in a primary care setting. Mental health services are covered under Medicare Part B, and the parity rules that took effect in recent years mean Medicare Advantage plans must cover mental health services at the same level as physical health services. Vaccine coverage. Medicare covers the shingles vaccine, pneumococcal vaccine, COVID-19 vaccines, flu shots, hepatitis B vaccine, and RSV vaccine at no cost under Part D or Part B, depending on the specific vaccine and how it's administered. Ask your pharmacist or doctor to confirm which vaccines you're current on. Dental, vision, and hearing. This is the area where Original Medicare, Parts A and B, has the most significant gap. Standard Medicare does not cover routine dental care, routine vision exams and glasses, or routine hearing exams and hearing aids. This is one of the most common sources of financial surprise for Medicare beneficiaries who assume everything is covered. However, many Medicare Advantage plans, Medicare Part C, do include dental, vision, and hearing benefits. If you're on Original Medicare and paying significant out-of-pocket costs for these services, it may be worth comparing Medicare Advantage plans during the next open enrollment period to see whether switching would reduce your overall costs. Open enrollment runs from October 15th to December 7th each year. Changes take effect January 1st of the following year. I covered this briefly in another video, but I want to go deeper on it today because the scale of what's being missed here is genuinely staggering. Medicare savings programs are state-administered federal programs that pay some or all of your Medicare premiums, deductibles, and cost sharing on your behalf. At minimum, even the most basic level, a Medicare savings program pays your $202.90 per month Part B premium. That's $2,434.80 per year, back in your pocket, for nothing other than applying. And here's the number that should make everyone paying that premium call their state Medicaid office this week. According to the Centers for Medicare and Medicaid Services, roughly 1.25 million people who already receive extra help for their prescription drugs also qualify for a Medicare savings program, but are not enrolled. 1.25 million people who qualified for one program, who went through an application process and got approved, who are receiving benefits, and who also qualify for a separate program that would pay their Part B premium, have simply never applied for the second one. On top of that, NCOA estimates the overall Medicare Savings Program participation rate is only about 49%. That means roughly half of all eligible people are not enrolled. Half. Let me walk through the 4 Medicare Savings Programs so you understand exactly what each one offers. The Qualified Medicare Beneficiary Program, QMB, is the most comprehensive. It pays your Part B premium, your Part A premium if you have one, your Part A and Part B deductibles, and most of your copayments and coinsurance. If you're enrolled in QMB, providers who accept Medicare are not allowed to bill you for Medicare cost sharing. This is a right that many QMB members don't know they have. If you're on QMB and a doctor or hospital has been sending you bills for copays, those bills are not legal, and you can report them to 1-800-MEDICARE. The Specified Low-Income Medicare Beneficiary Program, SLMB, pays your Part B premium only. No deductibles, no copays covered. But that premium payment alone is worth $2,434 per year. The Qualifying Individual Program, QI, also pays the Part B premium. It has slightly higher income limits than SLMB, making it accessible to people with somewhat higher incomes. Important detail: QI operates on a first-come, first-served basis with limited funding each year. If you think you might qualify for QI, apply as early in the calendar year as possible. The Qualified Disabled and Working Individuals Program, QDWI, covers a narrower group of people who return to work after receiving disability benefits and need help with Part A premiums specifically. Who qualifies? The income limits for QMB and SLMB are higher than most people assume. And here's the critical thing about assets for Medicare savings programs that's different from some other benefit programs. There is no look-back period on your home. Your primary residence does not count against you. Your car, your personal belongings, your household goods, these are not counted either. The asset limits apply to countable assets like bank accounts and investments above certain levels. Many people who assume they have too much to qualify are wrong because they're counting assets that the program specifically excludes. How to apply? Contact your state Medicaid office. You can find your specific state's contact through Medicare.gov under Get Help with Costs. The application takes roughly 30 minutes and asks about your income, your assets, and your household situation. Processing typically takes a few weeks. And here's the stacking benefit I want to make sure everyone hears. If you're approved for any Medicare savings program, you automatically qualify for extra help for your prescription drugs without a separate application. One approval, two benefits. That's potentially $2,434 in annual premium savings, plus up to $6,200 in prescription drug savings from a single application. Let me spend some time on Medicare enrollment and open enrollment rules, because the mistakes people make here create problems that can follow them for years, including permanent premium penalties that never go away. There are multiple enrollment periods in Medicare, and understanding which one applies to your specific situation is critical. The initial enrollment period runs for 7 months, starting 3 months before the month you turn 65 through 3 months after. This is your primary window to enroll in Medicare Parts A, B, and D when you're first becoming eligible. Missing this window without a valid reason leads to late enrollment penalties. The Part B late enrollment penalty is 10% of the standard premium for every full 12 months you were eligible but not enrolled. This penalty is permanent. It is added to your Part B premium for as long as you have Medicare. If you were eligible for Medicare for 3 years but didn't enroll, your Part B premium is permanently 30% higher than the standard rate. That's a penalty you pay every month for the rest of your life. The Part D late enrollment penalty is similarly permanent, roughly 1% of the national base beneficiary premium for each month you went without creditable drug coverage after becoming eligible. Now here's where people run into trouble. The most common reason for missing the initial enrollment period without penalty is having employer coverage through your own or your spouse's active employment. If you're still working at 65 and covered by a large employer plan, you generally can delay Medicare enrollment without penalty and enroll during a special enrollment period when that coverage ends. But if you're covered under a retiree health plan, not an active employment plan, that retiree coverage does not qualify as creditable coverage for Medicare delay purposes. People who assume their retiree health plan lets them delay Medicare without penalty are often wrong, and they discover the error only when they try to enroll later and find they owe a permanent premium penalty. If you're approaching 65 and you have any employer coverage, active or retiree, call 1-800-MEDICARE and ask specifically, does my current health coverage qualify as creditable coverage for purposes of delaying Medicare enrollment without penalty? Get the answer in writing if possible. The annual open enrollment period runs from October 15th to December 7th each year. During this window, anyone already on Medicare can switch plans, from original Medicare to Medicare Advantage, from Medicare Advantage back to original Medicare, from one Part D plan to another. Changes take effect January 1st of the following year. A lot of people set their Medicare plan once and never revisit it. That's a mistake. Your plan's premiums, coverage, drug formulary, and network of providers can all change from year to year. A plan that was the best value for your specific needs in 2024 may not be the best value in 2026. Spending 1 hour during open enrollment each year comparing your current plan against alternatives on Medicare.gov can save meaningful money. The Medicare Advantage open enrollment period runs from January 1st to March 31st each year. If you're in a Medicare Advantage plan and you're unhappy with it, this window lets you switch to a different Medicare Advantage plan or go back to original Medicare and add a Part D plan. This is a narrower window than the fall open enrollment, but it exists specifically for people who realize after January 1st that their plan isn't working for them. The last thing I want to cover today is one that's happening somewhat quietly behind the scenes, but that will eventually affect almost every Medicare Part D beneficiary. Under the Inflation Reduction Act, Medicare is now negotiating drug prices directly with pharmaceutical manufacturers for the first time in the program's history. This is a fundamental structural change to how Medicare drug coverage works, and the savings it generates flow directly to beneficiaries through lower costs on the negotiated drugs. The first drugs to have negotiated prices were announced in 2024, with those prices taking effect in 2026. The list includes some of the most commonly used and most expensive medications in the Medicare program: drugs for diabetes, heart disease, blood thinners, and other widely prescribed conditions. Here's what this means practically. If you are on one of the drugs that has been through Medicare negotiation, your out-of-pocket costs for that specific drug may be lower in 2026 than they were in prior years, depending on your specific Part D plan and how your plan has structured cost sharing for negotiated drugs. To check whether any of your current medications are on the Medicare negotiation list, go to Medicare.gov and use the Drug Coverage Finder tool. Enter your medications and your current plan information, and the tool will show you your estimated out-of-pocket costs for each drug under your current plan. You can also use this tool during open enrollment to compare whether switching plans would reduce your costs on your specific prescriptions. The negotiated drug list will continue to grow in the coming years. Medicare is required by law to negotiate prices for additional drugs each year through 2029. For anyone on high-cost medications, checking this list annually is worth the 5 minutes it takes. Let me bring all 5 of today's changes together into a clear action list. For the $2,000 drug cost cap, if you're on high-cost specialty medications, verify with your pharmacy that your plan is tracking your out-of-pocket spending correctly toward the $2,000 cap. Ask about the Medicare prescription payment plan if spreading costs monthly would help your budget. And when your cap approaches later in the year, think about whether to fill upcoming prescriptions before or after the January 1st reset. For IRMA, check your current Medicare premium notice. If you're paying above the standard $202.90, you're in an IRMA tier. If your income drops significantly since 2024 because of retirement, death of a spouse, or another qualifying life event, download Form SSA 44 from ssa.gov and file the appeal as soon as possible. Every month you delay is a month you continue overpaying. For preventive care benefits, call your doctor and schedule your annual wellness visit if you haven't had one this calendar year. Use those exact words when you call. Confirm which cancer screenings are due based on your age and risk factors and get them scheduled. Ask about any vaccines you may not be current on. For Medicare savings programs, if your income is anywhere near the thresholds, roughly individual income under $22,000 per year or joint income under $30,000 per year, contact your state Medicaid office and ask specifically about QMB, SLMB, and QI eligibility. Don't assume you don't qualify. The asset calculations exclude your home, your car, and most personal property. Apply now because QI in particular fills up during the year. For open enrollment, mark your calendar for October 15th. 1 hour on Medicare.gov comparing your current plan to available alternatives based on your specific medications and providers can save hundreds of dollars in 2027. Don't skip this just because your current plan feels familiar. For drug negotiation savings, visit Medicare.gov and use the drug pricing tool to check whether any of your current medications have negotiated prices in 2026. If they do, confirm your plan's cost sharing for those drugs and compare alternatives during open enrollment. Now, Medicare changes every year, and every year the people who know about the changes pay less. The people who don't know about them keep paying the old amount, sometimes hundreds of dollars more per year, for no reason other than not having the information. Today we covered 5 specific changes that are directly affecting how much Medicare costs you in 2026. The $2,000 drug cap that is protecting people on high-cost medications. The IRMA surcharge that most people don't know they can appeal. The preventive care benefits that have been part of your coverage all along, but that most people have never used. The Medicare savings programs that are paying premiums for people who know to apply. And the drug negotiation savings that are lowering costs on some of the most common and expensive medications in the program. 5 changes, real money, specific actions you can take today. If someone in your life is on Medicare and dealing with high drug costs, unexpected premium bills, or expenses they assume were just unavoidable, send them this video. Some of what they're paying doesn't have to be paid. They just need the information to know that. Subscribe to this channel. Open enrollment is coming in October, and between now and then, I'll have more specific guidance on exactly how to compare plans, what to look for, and what questions to ask. You don't want to miss that before the window opens. I'll see you in the next one.